Thank you, Dr. Miller, and also want to thank the organizers, Guillermo, Elba, Jacinta, for organizing this beautiful meeting. And thanks for the invitation to give this talk entitled A Tale of Two Viruses, Unusual Manifestations of Viral Infection in Renal Transplants. My partners in crime are Sarah and Dr. Tim Fields, who will be at the meeting, although unfortunately not until later today. So this is a slide that I showed at Ultrapa 20 in Amsterdam 4 years ago in a talk about infectious diseases that describes mechanisms of pathogenesis, how an infectious organism can injure an organ or tissue. It turns out there are a lot of different ways. You can certainly have direct infection of the tissue or organ, and that happens a good bit. Another major category is hypersensitivity reactions to the pathogen, which can either be remote or local. And a couple of things that will be relevant as this talk goes on are excessive production of cytokines. So the immune system makes a lot of cytokines trying to fight off the organism. And it turns out that some cells, particularly podocytes in the renal glomerulus, can be injured by excessive quantities of cytokines. And so you get an unintended damage to a tissue. And then immune complex formation. So the humoral immune system makes antibodies against the infectious agent. They complex with the antigens, and those insoluble immune complexes deposit, particularly in microvasculature. It turns out the glomerular capillary loops are a major target for this. So keep those things in mind. Some viruses, particularly well-known Epstein-Barr virus and human papillomavirus, can cause neoplasm. So they transform cells and can lead to tumors. There are a number of other viruses that can do this, including BK polyomavirus. And then finally, sometimes the drugs that we use to treat infections, antimicrobial agents, can be damaging to tissues and organs themselves, either through an allergic reaction or direct toxicity. So a lot of things to think about. This is just a paper that Tim Fields and I published 20 years ago about post-infectious or infection-associated immune complex glomerulonephritis in kidney transplant recipients. So this certainly can happen. Keep that in mind. So let's get on to the main story here. So Dr. Seuss had a character called the Cat in the Hat. And the Cat in the Hat had two mischievous henchmen called Thing 1 and Thing 2. So we're going to talk about Virus 1 and Virus 2. We'll start with Virus 1. We'll begin with a biopsy from a 65-year-old female who had end-stage renal disease. She'd had a kidney transplant, deceased donor kidney transplant, about a month before this all happened. And her serum creatinine went up, indicating that the organ was not working well. And she also developed proteinuria, protein in the urine. And she had some infectious things lurking in the background. She had Clostridium difficile infection. It was also known that her donor for the kidney was positive for Staphylococcus aureus, and she'd been treated for that. So anyway, because of this elevated creatinine and proteinuria, she got a renal biopsy. And here it is on H&E stain at low magnification, and over here at much higher magnification. And this glomerulus is just chock full of inflammatory cells. This is a neutrophil down here. There are a lot of cells that have a kidney-shaped or reniform nucleus that are probably monocyte macrophages. So there's way too many cells here. And here are a couple of special stains that we perform on renal biopsies routinely. One on the left is a PAS, or periodic acid shift stain, which stains carbohydrates. And there's lots of carbohydrates in capillary loop basement membranes and mesangium. Immunoglobulin heavy chains are also heavily glycosylated, and so they will stain with the PAS stain. So here's a capillary loop basement membrane. And basically, all of these capillary loops are chock-a-block with inflammatory cells. And this is a Jones silver stain, which is a more specific stain for basement membranes and matrix material. And Sibel Erdogan, in her really nice introductory talk yesterday about the findings in renal biopsies, pointed out that a normal basement membrane in the capillary loops is a single layer. But sometimes it doubles into something called a duplication or tram track. And this often, not always, but often, means that there's a subendothelial immune complex deposit sitting between these two tram tracks. So here's immunofluorescent staining on this biopsy, and there is indeed staining for IgG. Some of it looks like it's in little polygonal clumps that could be mesangial areas, but there are other sort of loop-like things that look like capillary loop staining. And there's somewhat stronger staining for C3, so a complement component. There's fairly equal staining for kappa and lambda light chains, so it's a polyclonal deposit. We had a nice talk about polyclonal immunotactoid glomerulopathy last night. So here's the electron microscopy, and there are indeed deposits. They're mostly subendothelial. And it's just, you can sort of imagine this is an immune complex deposit, except it's got this funny sort of spheroidal structure. It's made up of little round things. Wasn't quite sure what to make of that. Here it is at higher magnification. This patient had a subsequent biopsy, showed even more of this stuff. A lot of it is within basement membranes. This is a capillary endothelial cell, and it's got two structures in it. And Seibel also mentioned these in her talk. They're called tubular reticular inclusions. You can see them in patients with lupus, and you can also see them in patients with viral infections, most commonly in human immunodeficiency virus infection, but can be seen with other viruses. Finally, here's one additional higher magnification view. Here are little spherical structures, whatever they are. And see from the magnification bar down in the lower right, that bar is 200 nanometers. And these things, fairly uniform in size, are about a tenth of the length of the bar. So about 20 nanometers in diameter. So didn't know quite what to make of this, but I sort of assumed that the little spherical things were just degenerating immune complex deposits. And we call this acute glomerulonephritis consistent with resolving phase of infection-associated immune complex glomerulonephritis. So there the matter sat for several months. I didn't really think too much more about it. And then I got an email from Tim Fields saying, could you look at a renal transplant biopsy that I've just received on a 67-year-old guy with end-stage renal disease who had a kidney transplant about 4 months ago. His creatinine started to go up. And the thing that's a little bit different in the story for this patient is that someone had thought to do a parvovirus B19 polymerase chain reaction test on this patient. And it ended up he had a really high titer parvovirus B19 viremia. So he got a renal biopsy. I don't have pictures of the light or fluorescence microscopy, but it sounds a lot like what I just showed you on our index case, which is to say that the light microscopy showed a membranoproliferative glomerulonephritis, and the immunofluorescence showed staining for C3 and IgG with more C3 than IgG. So that sounds kind of familiar. Here's the electron microscopy, and this is a capillary loop-based membrane. They're what look like immune complex deposits. And you look carefully, there's some little round things embedded within this immune deposit. And they're much more prominent in other areas. This looks a lot like what we saw in our patient's biopsy. And here's another one at high mag. I don't have magnification bars here, but Tim measured these very carefully. And they're all about 20 nanometers in diameter. So this is about the right size for one of those small round viruses that Sarah was just talking about. So suddenly the light went on in my head, and I said, this is about the right size for a parvovirus particle. So Tim sent us some paraffin sections, and our laboratory did immunohistochemistry for parvovirus B19, and it was strongly positive in this sort of granular pattern. At that point, another light went on in my head, and I said, oh, this looks like the case we had 6 months ago. So I went back and did immunohistochemistry for parvovirus B19 on our patient, and it was also positive. So what are these round things? Well, my original thought was it was just a degenerative product of immune complexes, and there is a precedent for that, which was mentioned last night in the form of this membranous nephropathy with spherules. And this is a case of membranous nephropathy with spherules from my own practice. Probably one of the things that was mentioned in the differential last night was podocytic enfolding glomerulopathy, but I think this is too much to be considered to be likely to be that. So I think this is a degenerative process. They look a little bit like virus particles. They're too big to be parvovirus. They might be something like a polyomavirus. But remember, Sarah says spherical particles should be very uniform in size, and these are not uniform in size. They're big ones and little tiny ones. So that's a clue that this is degeneration of an immune complex rather than a virus particle. Now, second possibility, I mentioned that pathogens, including viruses, can directly infect tissues. So could this be a direct infection of the kidney by a parvovirus? Now, the problem with that is that, as Sarah pointed out, DNA viruses typically replicate in the nucleus. And this is a picture of an actual parvovirus infection from a book chapter she wrote about 16 years ago. And this is by no means the most beautiful micrograph that Sarah has ever taken. It was a little piece of sort of poorly fixed tissue that she got from a colleague at a different institution. And then she took the picture. It was published in a book that was printed on non-glossy paper. And then I made a scan of that to show you here. So not her best work. But you can see this big virus factory in the middle of this cell, which is probably a red cell precursor. And up here you can see the particles. They're a little hard to make out, but they're about 20 nanometers in diameter. So we didn't have anything that looked like this in our case. All of the particles were extracellular. So it's probably not a direct infection of the tissue. So the third possibility is that these things actually are virions, but they got to the kidney, say, via the circulation, and they've gotten entrapped in immune complexes. Well, can you have virus particles entrapped in immune complexes? Well, there is a precedent for that, and it's in the form of a very lovely paper by our own John Braley, which was published in Ultrastructural Pathology almost 20 years ago. So this is from a patient who had BK virus, polyomavirus associated nephropathy, but also had subepithelial immune complex deposits. And so this is a picture from the beautiful illustrations in John's paper of an intranuclear paracrystalline array of polyomavirus particles. But here is one of these subepithelial hump-like immune complex deposits. This is the glomerular basement membrane. And within this, you see these little spherical uniform particles, which are about 40 nanometers in diameter. The mag bar here is 150 nanometers. So I think the cases from Tim's lab and our laboratory are actually virions entrapped within immune complex deposits. This is my favorite interpretation. One of the two patients, Tim's patient, had documented parvovirus B19 viremia. Our patient was unfortunately not tested. And this is a very small virus. It's about 20 nanometers in diameter. The capillary loop endothelium is fenestrated, so it has holes in it that might be large enough to allow a polyomavirus particle to get through them and get stuck in the subendothelial space associated with immune deposits. And we actually submitted this case for publication that has just been accepted in transplant proceedings. And there is one other case report that has come out since we started working on this. So we now have 3 cases like this. And I sort of wonder whether they are maybe the leading edge of some sort of an evolving problem that we're going to see more of. Now, it turns out that there's fairly well-characterized association of parvovirus B19 and renal glomerular disease, but it's very different from what I've just shown you in these 2 cases. Now, I'll show you an example. This is actually a native kidney biopsy from a 16-year-old male who had acute kidney injury, proteinuria, and hypoalbuminemia. So his glomeruli look very different. So most of them look like the one on the left over here, which is fairly normal looking in this H&E stain. One on the right has glomerular tufts that seem to be sort of crunched down or collapsed, and they're surrounded by this scrum of reactive epithelial cells, some of which contain protein resorption droplets that are eosinophilic. And here are PAS and Jones silver stains showing the same thing. You see these collapsed tufts with this sort of florid proliferation or accumulation of epithelial cells. This is called a collapsing glomerulopathy. The immunofluorescence on this case was negative, and by electron microscopy, there wasn't any evidence of any kind of deposit. Nothing looked like any kind of viral particle. Here's a capillary lumen, basement membrane, mesangial area, no deposits. The key finding here is that the podocyte foot processes are diffusely effaced. So this is a podocytopathy with early collapsing glomerulopathy. And this patient was based on those findings, tested for a couple of things. One was parvovirus B19, and patient did have a positive PCR for parvovirus. And that also had genetic testing for risk alleles of APOL1 and was found to be a compound heterozygote for 2 risk alleles. Both of these things, and actually frequently acting together, can predispose to collapsing glomerulopathy. And this probably doesn't have anything to do with direct infection of the kidney or deposition of virus particles from the circulation. The parvovirus probably induces a cytokine response that damages the podocytes, which are predisposed to the damage by the APOL1 mutation. We actually did immunohistochemical staining in this case for parvovirus B19. It was negative. This is the positive control, just to show you that the stain worked. So virus 1 is parvovirus B19. On the right is a picture of Dr. Yvonne Cossart, a very fine Australian microbiologist who discovered parvovirus B19. And Yvonne happens to be, or was, she sadly passed away about 10 years ago, the husband of Dr. Ted Wills, who Sarah mentioned. And Yvonne and Ted hosted Sarah and me for 3 days in Sydney more than 20 years ago. It was one of the most wonderful times we've ever had. The most consummate, gracious hosts. Okay, on to virus 2, and this one's shorter. I realize I'm probably getting close to the end of my time. This is a biopsy from a 57-year-old man, also recipient of renal transplants. Actually had one more than 20 years prior that failed and had a retransplant about 1.5 years before. Creatinine went up. This guy had been tested routinely by polymerase chain reaction for circulating BK polyomavirus, a common pathogen in renal transplants. And our patients get tested for it routinely and been persistently negative for the entire time of the transplant. He had a brain lesion after the second transplant and had a spinal tap, and cerebrospinal fluid was positive for Epstein-Barr virus by polymerase chain reaction. And he was treated presumptively for post-transplant lymphoproliferative disease. And the brain lesion, for whatever reason, went away, either because of the treatment or in spite of it. So here's what his biopsy looked like. And there's some glomeruli here in this medium power view that look pretty normal, but there's a huge amount of interstitial inflammation. And if you look closely, you can see a lot of tubular epithelial cells that have sort of a ground glass nucleoplasm. And then over here, there's a cell that's got a small hyperchromatic nucleus. And anyone who looks at renal transplant biopsies will say, this is classic for BK polyomavirus associated nephropathy. The patient had been persistently negative for BK virus, though, and I almost said, well, no, it can't be that. But I went ahead and did an immunohistochemical stain. The antibody we use is against a laboratory strain of polyomavirus, SV40, and it cross-reacts with both BK virus and the JC virus. That's the typical pathogenic agent for progressive multifocal leukoencephalopathy. And this is strongly reactive. So they're all over the place here, although notice that there are a lot of areas where there isn't any staining. So I called this polyomavirus-associated nephropathy and suggested to the clinicians that they go back, since the BK virus PCR had been negative, and do a JC virus PCR. And this was subsequently found to be strongly positive. And then it turns out on review that this cerebrospinal fluid that had been obtained several months before had also been tested for JC virus, and that PCR was positive. So this patient doesn't have BK virus associated nephropathy. They got a JC virus associated nephropathy. And this has been reported, but it's very rare. Now, unfortunately, that patient was not studied by electron microscopy. I'll show you what polyomaviruses look like in the kidney. This is BK virus. This is in a thin section. Sarah talked about thin sections versus negative staining. This is paracrystalline arrays of particles in a tubular cell nucleus. The much more efficacious way of looking for this is by negative staining of urine. And the nice thing about it is that it's agnostic for the different kinds of polyomavirus. It will see both JC virus and BK virus. So this would be a really good way, or would have been a good way, of screening our patient, and it would have sort of solved the question for me before I had to guess and say maybe this patient's got JC virus. These particles in the negative stain are about 40 nanometers in diameter. As Sarah pointed out, they're uniform in size. And this is actually a figure from a paper that Sarah and I published almost 30 years ago in Transplantation on the efficacy of using negative staining of urine to diagnose BK polyomavirus infections, or JC as it happens. So the second virus is JC polyomavirus. And I'll close here by showing you a few things that I think might be helpful hints in avoiding the diagnostic pitfall of missing one of these things. First, be on the lookout for something unusual, something that's rare to begin with, something that's not necessarily rare, but it's in an unexpected organ, like JC virus in the kidney instead of the brain. Something that's in an unexpected location, like parvovirus particles that are in the extracellular space rather than in nuclei. Use the clinical history, but don't get blinded by it. So our last patient had negative PCR for BK virus. It would have been easy to say, well, this can't be a polyomavirus infection because that's negative. Don't be hamstrung by what the history tells you. Utilize consultants liberally. So in the parvovirus cases, neither Tim nor Sarah nor I would have figured it out by ourselves. The way we got to the final diagnosis was by putting our heads together and figuring it out. And finally, use all available diagnostic modalities, particularly electron microscopy. And with that, I'll stop. Beware lookalikes.